This conference will now be recorded.
Today's topic is OpenGlobe injuries. What is this first picture? This one? Anyone? Samba 84. What is this first picture? Number 10. Sony 58. What is the first picture? The second one, can you tell, anyone tell? What is the second picture? Ramesh, Danny, Arnab. Can anyone tell what is the second picture? Ravi? This is a subconjunctival hemorrhage. What do you see in this fundus? Dilated. The red thing. What is this one? Geetika. What is this red thing that is present inside the eyeball? This red thing is the vitreous hemorrhage. Hemorrhage in the vitreous. This one is a subconjunctival hemorrhage due to blunt trauma. And this one is the fish hook injury. The foreign body penetrating into the corneosteal junction due to flipping of the fish hook. This is a fish hook injury. This one is also blunt trauma resulting in subconjunctival hemorrhage, severe subconjunctival hemorrhage, distortion of the iris, corneal edema due to raised intraocular pressure, subluxation of the lens into the anterior. This is the lens subluxated into the anterior chamber. This one, perforating injury. This is the perforation of the cornea. You can see here. This white line is the central corneal perforation. This is the rupture of the globe resulting in subconjunctival hemorrhage, dislocation of the lens, and distorted pupil here. What is this one? Foreign body. Thorn. Most probably some kind of thorn. And this one? What is this called? Chandu. Krishnaveni. What is this one called? This picture. Kranti.
Congestion, sir.
No, not congestion. What you can see here? This one is congestion. The first one is this one. Blood in the anterior chamber. What is the condition called? Blood in the anterior chamber.
Hyphema, sir. Hyphema, sir.
Good, good, excellent. This one. This way, keeping the
Photophobia, sir.
photophobia. This one. This one. Watering, epipora or watering. This is congestion. This is hyphema, blood in the anterior chamber. What will you do for blood in the anterior chamber? Surya, Kamalika. What is the treatment for blood in the anterior chamber? జస్ట్ వచ్చి వెళ్ళిపోతున్నారు కొంతమంది. Tejasri Kolla. What is the treatment for blood in the anterior chamber? You have to, for mild cases, it resolves spontaneously. For severe cases like this, you have to wash the blood. To paracentesis, you have to remove the blood. Otherwise, it will stain the corneal endothelium and damage the corneal endothelium. The hemocysteine liberated from the lysyl RBC cells gets deposited in the corneal endothelium and will cause damage to the endothelium, cause staining of the endothelium. So that causes blurring of the vision. So you have to wash the IFIMA. For severe cases like this, you should not wait for more than 24 hours. You should wash the IFIMA through paracentesis. You should make a paracentesis side port here. Through the side port, you have to wash the IFIMA and keep the air bubble to prevent further bleeding. This is IFIMA. This is photophobia. This is lacrimation or watering. This is the congestion, conjunctival congestion. What is this one? Thysis bulbi. See, you can see the difference between the size of the eye between this and this, right and left. The eyeball has shrunken, cornea is reduced in size. That is why it is called thysis bulbi. What is this one? Blunt trauma resulting in distortion of the iris and traumatic cataract. You can see here, white one here. This one is a traumatic cataract and this is the distortion of the iris. This picture, what is this picture? This is a conjunctival laceration. You can see here. There is split in the conjunctiva. You can see the underlying Tenon's capsule. This is the conjunctival laceration. This is also subconjunctival hemorrhage. This one is also subconjunctival hemorrhage only. Severe subconjunctival hemorrhage. This is the conjunctival laceration. You can see the split in the conjunctiva with the subconjunctival hemorrhage. This is the subconjunctival hemorrhage and this is the laceration of the conjunctiva. This one, perforation of the cornea to the limbus, and you can see the iris prolapse here, uveal tissue prolapsing from the underlying sclera. You can see here. Total corneal laceration, multiple lacerations here. You can see the lens matter in the anterior chamber and perforation of the uveal tissue from the sclera. Here, iris prolapse, you can see here. This is the iris prolapse. Corneal damage with iris prolapse. This one is also traumatic cataract. Rosette shaped cataract or traumatic cataract. Traumatic cataract is rosette shaped. Ocular trauma, it is the damage or trauma inflicted to the eye by external means. It includes both surface injuries and intraocular injuries. During trauma, soft tissues and bony structures may be involved. Sometimes soft tissues can be involved, sometimes bony structures can be involved. Sometimes both soft tissues and bony structures can be involved during trauma. Ocular injuries are again divided into mechanical and non-mechanical injuries. Mechanical, extraocular foreign bodies, blunt trauma, perforating injuries, intraocular foreign bodies, penetrating injuries, and sympathetic ophthalmology. These are the mechanical causes for ocular injuries. Extraocular foreign bodies, blunt trauma, perforating injuries, intraocular foreign bodies, penetrating injuries, sympathetic ophthalmology. These are the mechanical causes for ocular injuries. Non-mechanical causes includes chemical burns like acid burns, alkali burns, thermal injuries, electrical injuries, and radiational injuries. Radiational injuries is again divided into UV radiation, infrared radiation, and ionizing radiation. These are all the non-mechanical causes. Chemical burns, thermal burns, electrical injuries, and radiation injuries are the non-mechanical causes. Whereas mechanical causes includes foreign bodies, blunt trauma, perforating injuries, penetrating injuries, and sympathetic ophthalmology. This is the classification of ocular injuries: non-mechanical and non-mechanical. Any trauma, penetrating, perforating, foreign bodies, all these causes mechanical injuries. Acids, thermal injuries, electrical injuries, and radiation injuries are non-mechanical injuries. This is the Birmingham's high trauma terminology, BET. This is the classification for ocular trauma. BET is the classification. Birmingham's high trauma terminology is the classification for ocular trauma. It is divided into closed globe injuries and open globe injuries. Closed globe injuries are divided into contusion and lamellar laceration. Open globe injuries are divided into laceration, rupture. Laceration is again divided into penetrating, perforating, and intraocular foreign bodies. Injury is divided into closed globe and open globe. Closed globe is again divided into contusion and lamellar laceration. What is the difference between lamellar laceration and laceration? Lamellar means partial. That is why it is called closed globe. Whereas laceration means complete laceration, complete splitting of all the layers. That is the difference between lamellar or laceration. Lamellar laceration and laceration. Lamellar is partial, that is why it is closed globe. Whereas laceration is complete, that is why it is open globe. That is the difference between lamellar laceration and laceration. And laceration is again divided into penetrating, perforating, and intraocular foreign bodies. This is a classification, BET classification, Birmingham's eye trauma terminology. It is defined as the full thickness wound of the eye wall through the sclera and cornea, divided into globe rupture and globe laceration. Globe rupture refers to full thickness wound of the eye wall caused by impact of blunt object due to raised intraocular pressure. Globe rupture occurs due to blunt trauma resulting in raised intraocular pressure by inside-out injury. Whereas globe laceration refers to full thickness corneal or scleral wound caused by sharp object. It is caused from outside to inside. Whereas globe rupture results from inside to outside. Due to raised intraocular pressure from blunt trauma, the rupture occurs from inside to outside. Whereas laceration occurs from outside to inside. Refers to full thickness. Both are full thickness laceration only. But rupture is from inside to outside, whereas laceration is from inside to outside. Laceration is from outside to inside. This is the perforating globe injury. This is the perforation of the cornea. You can see the corneal perforation here. This is the globe rupture resulting in subcontinental hemorrhage. Hypotone, you can see the somewhat shrinking of the eyeball. Low intraocular pressure. Lens in the anterior chamber. Irregular pupil, dilated and irregular pupil. This is the globe rupture, picture of globe rupture. This is the corneal perforation, perforating globe. Globe lacerations includes penetrating injuries, perforating injuries, penetrating injury refers to single laceration of the eye wall caused by sharp object which travels coats only once. Whereas perforating injury refers to full thickness lacerations. One entry and one exit of the eye wall caused by a sharp object or missile. There will be both entry and exit wounds. Perforation results in both. There will be both entry wound and exit wound. Whether penetrating, there will be only one entry will be there. That is the difference between penetration and perforation. Penetration contains only single laceration, whereas perforation contains two lacerations. There will be an entry wound and an exit wound. That is the difference between penetration and perforation. Technically, penetrating injury is associated with retained intraocular foreign body. Modes of injury: trauma by sharp and pointed instruments like needles, knives, arrows, screwdrivers, pens, pencils, compasses, gas pieces, and so on. Trauma by foreign bodies: traveling at a very high speed, such as bullet injuries and iron foreign bodies in lathe workers. This is the thorn foreign body in the eye. You can see the thorn here. Mechanical effects of trauma includes laceration of the conjunctiva and cornea. There can be a vitreous hemorrhage, rupture of the globe, retinal tears and retinal detachment, scarring of the wound leading to cataract and glaucoma, intraocular foreign bodies. Why there is glaucoma in trauma? Any blood or any lens matter will block the trabecular mesh, or sometimes the lens, dislocated lens itself can block the trabecular mesh and cause raise in intraocular pressure. It can result in open angle glaucoma or closed angle glaucoma. When the entire lens is dislocated in the anterior chamber, it will cause closed angle glaucoma. Or it may push in the iris diaphragm forwards and causes closed angle glaucoma. Or the lens matter or ephema that blocks the trabecular mesh and causes raise in intraocular pressure and causes secondary open angle. Blunt trauma can cause either of the either it can cause angle closure glaucoma or either it can cause open angle glaucoma. It can also cause retinal tears, later retinal detachment, rupture of the globe, vitreous hemorrhage. I have shown you first picture, vitreous hemorrhage, laceration of the conjunctiva and cornea, and intraocular formation. Any trauma can lead to introduction of infection. Sometimes the pyogenic organisms enter the eye during the OpenGlobe injuries, multiply there and cause varying degree of infection depending upon the virulence of the organisms and post-defense mechanism. Depending on the virulence of organisms and defense mechanisms, the pyogenic organisms which has entered the eye with the foreign body or globe injuries can multiply and cause varying degrees of infection. These varying degrees of infection includes ring abscess of the cornea. It can also result in sloughing of the cornea. It can cause purulent hydrocyclitis. It can also cause endophthalmitis and panophthalmitis. What is the difference between endophthalmitis and panophthalmitis? Pan means when all the layers of the eyeball, including the sclera, tenons, vitreous, uveal tissue, and all the layers are involved, it is called panophthalmitis. Endophthalmitis means only the inner layers, vitreous and the uveal tissue are involved. It is called endophthalmitis. Inflammation of the inner layers of the eyeball. Endophthalmitis. Panophthalmitis means involvement of all the layers, including the conjunctiva is involved. Clearly, tetanus by and infection by gas-forming organisms, Clostridium welchi, may occur. This is about the infection. Infection can cause ring abscess of the cornea, sloughing of the cornea, purulent hydrocyclitis, endophthalmitis, and panophthalmitis. Clearly, tetanus and infection by gas-forming organisms may also occur. Post-traumatic iridocyclitis is a common sequela to perforating wound and if not treated properly can cause devastating damage. Most dangerous complication of perforating injuries. And symptoms and signs includes redness of the eye. This is the redness of the eye. This is the ephema. This is the photophobia. This is the lacrimation. These are the symptoms and signs. Congestion, hemorrhage, redness of the eyes, lacrimation. This is the lacrimation, and this is the photophobia. This picture is the photophobia. Photophobia is difficulty to see the bright light. It's called photophobia. Itchy and watery eyes, blurring of vision or loss of vision. Here you can see the loss of vision will be there in traumatic cataract. This is a picture of phthisis bulbi or long-standing. Long-standing trauma can cause shrinking of the globe, cutting of the ciliary process, and shrinkage of the globe. That is called phthisis bulbi or atrophic bulbi. This one is a traumatic cataract with distorted iris. Change in pupil shape, blood or fluid leak from the eye, foreign objects penetrating the eye. Traumatic lesions with wounds of the conjunctiva, these are common and usually associated with subcontinental hemorrhage. This is the both are the pictures of subcontinental hemorrhage. But here you can see the conjunctival laceration also. This is a splitting of the conjunctiva. That is why it is called conjunctival laceration. A wound of more than 3 mm should be sutured. If the wound laceration, conjunctival laceration is more than 3 mm, it should be sutured. This is a picture of subcontinental hemorrhage. Wounds of the cornea, these can be divided into uncomplicated and complicated wounds. Uncomplicated corneal wounds, these are not associated with prolapse of the intraocular contents. Margins of such wounds swell up and lead to automatic sealing and restoration of the anterior chamber. A small central wound does not need stitching. The only treatment required is standard bandage with retrophin and antibiotic hydrochloride. The small central corneal perforation, as I have shown you in the previous pictures, there is no need for suturing, very small perforation. It can be sealed with standard bandage and atropine for dilatation and antibiotic ointment. A large corneal wounds of more than 2 mm should always be sutured because corneal laceration is more than 2 mm, it should be sutured. Complicated corneal wounds, these are associated with prolapse of the iris, sometimes lens matter, and even the vitreous. Complicated corneal wounds are associated with iris prolapse, lens matter, and prolapse of the vitreous. Small central corneal wounds with iris prolapse should be sutured meticulously with the help of intraocular myocol or pilocarpine, and wound is repaired with tango nylon sutures. Small corneal wounds are there. You should suture them with tango nylon sutures. First, you have to, if there is any iris prolapse, you have to replace the iris with the intracameral pilocarpine. What will intracameral pilocarpine will do? It will constrict the pupil and restore the normal anatomy of the iris. Then you have to suture with the cornea with the tango nylon sutures. If the iris appears non-viable, if the iris is dead, it must be excised and the edges of the wound sutured directly. This is about the iris prolapse, treatment of corneal injuries with iris prolapse. If the iris is viable, you should replace the iris into the normal position with the intracameral pilocarpine. It will constrict the pupil. Then you have to suture the cornea with tango nylon. If the iris is not viable, it is damaged, then you have to excise the damaged iris and suture the cornea. This is a picture of corneal tissue with iris prolapse. You can see here, uveal tissue prolapse here. Here also you can see the iris prolapse. Here also the corneal perforation with iris prolapse. If the iris is not viable, you should excise the iris. If the iris is viable, you do intracameral pilocarpine. Then you have to suture this corneal wound. Multiple interrupted wounds can be applied here. Here you can see. Should not apply the continuous suture here. You have to apply the interrupted sutures here. Horizontally. Here vertically. This should be sutured vertically. And this should be sutured horizontally. There are two lacerations here. One is horizontal and one is vertical. Here you have to excise the dead tissue and you have to suture the cornea. It is almost dead. The iris tissue is almost dead, not viable. Then you have to excise this iris and then you have to suture the cornea. Corneal wounds caused by any dirty foreign body. Pathogenic organisms are carried into the eye, multiply there and cause rapid necrosis of the entire cornea. Ring of deep infiltration appears 3 mm internal to the and concentric within the corneoscleral margin. It is called ring abscess. The 3 mm infiltration around the corneoscleral margin, it is called ring abscess. The organisms are Pseudomonas aeruginosa, anaerobic gram-negative organisms, extensive chemosis and conjunctiva, and greenish discharge. The Pseudomonas, if the infected organism is Pseudomonas, there will be extensive chemosis and conjunctiva, and there will be greenish discharge. Enzymes released by the organ called liquefaction of the cornea. Usually panophthalmic sets in and the whole of the central part of the cornea is cast off if it finds access into the anterior chamber. Pyogenic infection leads to purulent iridocyclitis with hypopyon, endophthalmitis, and usually panophthalmitis. These are sequelae. Pyogenic infection causes initially iridocyclitis, then hypopyon, then endophthalmitis, and lastly it results in panophthalmitis. Wounds of the sclera is usually associated with corneal wounds. Treatment includes, if the corneoscleral tear, first suture should be applied at the limbus. If there is a corneoscleral tear, both cornea and sclera are on, the first suture should be applied at the limbus. Scleral wounds of more than 3 to 4 mm posterior to the limbus are sutured completely after thorough exploration. You have to explore the conjunctiva, you have to remove the conjunctiva. If it has gone beyond the limbus, you have to remove the conjunctiva, split the conjunctiva and close the sclera first. Then you have to again close the conjunctiva. Surrounding cryo application is done to post chorioretinal adhesions. You have to apply the cryo for chorioretinal adhesions to prevent further retinal detachment. Extensive lens rupture with vitreous loss occurs. Traumatic cataract are always a serious complication. Mechanism of traumatic cataract formation: if the wound of the capsule is small, the entry of the aqueous causes localized cloudiness in the vicinity, and irrespective of the site of the wound, opacity is in the form of feathery lines. This is the feathery cataract, resulting in rosette-shaped cataract. Feathery lines appears in the posterior cortex, which later develop into rosette-shaped cataract. This is a rosette-shaped cataract caused by blunt trauma, resembling that of the early compression cataract. This is a traumatic cataract or rosette-shaped cataract. The wound in the capsule is small, it causes seeping of the aqueous and causes localized cloudiness in the vicinity. Irrespective of the sites of the wound, opacities appear in the form of feathery lines appear in the posterior cortex, which later develop into rosette-shaped cataract. If the posterior synechia develops, in which these cases changes may be stationary and they usually progress until the complete cataract is formed. If the lens is damaged, it rapidly opacifies and a flocculent gray mass protrudes through the opening in the capsule, sometimes filling the whole chamber. If the lens capsule is damaged, a gray matter protrudes through the opening in the capsule, filling the anterior chamber. The aim of the surgery is to remove the cataract, perform an adequate vitrectomy. If the vitreous is involved, we should perform an adequate vitrectomy, suture the globe as a primary procedure, and insert an intraocular lens. After removing the lens, you should keep an IOL. To ensure control of infection and inflammation, intraocular and topical antibiotics and steroids should be given. Risk factors for poor visual outcome includes double penetrating and perforating injuries, dense vitreous hemorrhage, blunt trauma as a causative factor. These are the risk factors for poor visual outcome. Double penetrating and perforating injuries, dense vitreous hemorrhage, blunt trauma, severe blunt trauma are all the risk factors for poor visual outcome. This is the small topic of OpenGlobe injuries. This is a fish-hook. First one is a, some of you are absent previously. This is a fish-hook injury. You can see the hook here. This one. This is a fish-hook injury. Here you can see the vitreous hemorrhage through the dilated pupil, and this one is a subfrontal hemorrhage. Ocular injuries are again classified into mechanical and non-mechanical injuries. Mechanical injuries are extraocular foreign bodies, intraocular foreign bodies, blunt trauma, perforating injuries, and sympathetic ophthalmitis. Non-mechanical includes chemical burns, thermal burns, electrical burns, and radiation. This is the classification of ocular injuries into mechanical and non-mechanical injuries. And this is the classification, Dept classification, Birmingham high trauma terminology. This is the classification for ocular trauma, divided into closed globe and open globe. We are discussing about the open globe. Open globe is again divided into laceration and rupture. Laceration is again divided into penetrating, perforating, and intraocular form. What is the difference between globe rupture and globe perforation? From inside out, it is called globe rupture. From outside to inside, it is called globe laceration. That is the difference between globe rupture and globe laceration. Refers to full thickness wound of the eye caused by impact of blunt object due to raised intraocular pressure. By inside out injury mechanism is called closed rupture. Full thickness corneal and scleral wound caused by sharp objects from outside in mechanism is called globe laceration. Due to raised intraocular pressure, there will be rupture from inside, that is called globe rupture. Whereas laceration is due to trauma, any sharp objects, it causes full thickness laceration from outside to inside. That is the difference between rupture and laceration. This is a perforating globe injury. You can see the central corneal perforation. This is the subcorneal hemorrhage with globe rupture. The lens in the anterior chamber, you can see that grayish white opacity in the anterior chamber. That's the lens in the anterior chamber. This is the dilated pupil and distorted pupil. You can see some hypotonia also. Here the shape of the eyeball is maintained. Where here is here, the shape of the eyeball is not maintained. You can see the hypotonia. This is a thorn, intraocular foreign body. There are the symptoms and signs. This is a picture of hyphema, where you have to remove the hyphema with paracentesis. You have to give a side port here and remove the hyphema and keep an air bubble to prevent further bleeding. Air bubble acts as a tamponade to prevent bleeding. This is the watering from the eyes, lacrimation. This is a picture of photophobia, inability to see the bright light. This is the congestion, conjunctival congestion. These are the symptoms and signs of trauma. This is a picture of thysis bulbi or atrophic bulbi. This is a blunt trauma resulting in traumatic cataract with distorted iris. This is the distorted iris, and this is the whitish opacity is the traumatic cataract. Signs of ocular rupture include hemorrhage, chemosis, and pupil irregularity. This is the pupil irregularity. This is a picture of conjunctival laceration. You can see the conjunctival laceration here. This is a subconjunctival hemorrhage. Picture of subconjunctival hemorrhage. This is a corneal tear with iris prolapse. Both these pictures are corneal tears with iris prolapse. The iris is normal. You have to give intracameral pilocarpine and suture the cornea. The iris is sloughed off or it is damaged, and you have to access the damaged iris and you have to suture the cornea. If there is any vitreous, you have to go for vitrectomy. If there is blood, we have to go for removing of the blood. Any foreign body will cause infection. It may result in iridocyclitis, ring abscess of the cornea, endophthalmitis, panophthalmitis. Particularly Pseudomonas aeruginosa causes greenish discharge. It causes greenish discharge. Extensive chemosis and conjunctiva and greenish discharge. Pseudomonas. Traumatic cataract results in rosette-shaped cataract. The aim of the surgery is to remove the cataract, perform an adequate vitrectomy to remove any blood or vitreous, suture the globe as the primary procedure, and insert an intraocular lens for traumatic cataracts. And risk factors for poor visual outcome in traumatic cataracts include double penetrating and perforating injuries, dense vitreous hemorrhage, blunt trauma as a target factor. These are the risk factors. Here you can see here clearly fish hook here. This is the hook. intraocular corneal body, tissue intraocular corneal. To the dilated pupil, you can see the vitreous hemorrhage, the reddish glow. That is vitreous hemorrhage. This is a very small topic. What are the mechanical effects of trauma? Mechanical effects includes laceration of the conjunctiva and cornea. It can result in vitreous hemorrhage. It can cause rupture of the globe. It can cause retinal tears and detachment. What is the rhegmatogenous retinal detachment? What is the rhegmatogenous? What are the types of retinal detachment? Rhegmatogenous, exudative, and tractional retinal detachment. Rhegmatogenous means rhegma means break. Through a break in the retina, there will be seepage of the fluid and causes detachment. That is rhegmatogenous retinal detachment. Exudative means inflammation. Any inflammation of the choroid causes exudation of the fluid and elevation of the overlying retina. That is exudative retinal detachment. Traction means pulling. Diabetic retinopathy or any types of Seals disease, where the fibrovascular bands will pull the retina away from the choroid. That is fractional retinal detachment. There are the three types of retinal detachment: rhegmatogenous retinal detachment, exudative retinal detachment, and tractional RT. There are the three types of RT. For rhegmatogenous retinal detachment to occur, there should be a pre-existing break. Through the break, the liquid vitreous will seep and causes lifting of the retina. And the exudative means there will be due to inflammatory causes, most commonly sports disease or any uveitis. There will be inflammation of the choroid. Whenever there is inflammation, there will be break in the blood retinal barrier, and fluid will seep between the retina and choroid and causes elevation of the overlying retina. There is exudative RT. Whereas tractional RT means there will be fibrovascular bands, diabetic retinopathy or Eats disease or sickle disease. These fibrovascular bands will pull the retina. That is why it is called tractional retinal detachment. For traction to occur, there should be some fibrovascular bands. Usually occurs in the advanced stage of diabetic retinopathy. That is tractional RT. There are three types of RT: rhegmatogenous RT, exudative RT, and tractional RT. So how will you manage exudative RT? Exudative RT is usually managed medical management. Or you can do a sclerotomy and drain the fluid because it is usually an inflammatory condition. Tractional RT, you have to do vitrectomy. You have to cut the tractional bands and tape and remove the vitreous and these fibrovascular bands. Any hemorrhage you should remove. You should do vitrectomy. For rhegmatogenous RT, you should usually do buckling, scleral buckling. These are the three types of RT. Retinal detachment is an important essay for you. For undergraduates also. For undergraduates and postgraduates is an important essay. Retinal detachment. You have to classify into rhegmatogenous retinal detachment, exudative retinal detachment, and tractional retinal detachment. Endophthalmitis is an important question. Which organism causes post-traumatic endophthalmitis? Bacillus cereus is an organism which causes most commonly post-traumatic endophthalmitis. It is an important essay question, entrance question for you. Which organism causes post-traumatic endophthalmitis? Bacillus cereus is an organism which causes post-traumatic endophthalmitis. And the drug of choice for post-traumatic endophthalmitis is IV ciprofloxacin. Is a drug of choice for post-traumatic endophthalmitis. So, what is the treatment for endophthalmitis? What will you do whenever there is a suspected case of endophthalmitis? First, you have to remove 1 mm of vitreous to the pars plana and send for culture and sensitivity for organism. Then you have to go for intravitreal drugs like vancomycin and ceftazidime. Vancomycin is a broad spectrum antibiotic. It has effect against both positive, gram-positive and gram-negative organisms, but predominantly against gram-positive organisms. Ceftazidime is for gram-negative organisms. You do vancomycin and ceftazidime along with that vancomycin and ceftazidime. You should give dexamethasone also to reduce the inflammation. Intravitreal injections. If there is no response to intravitreal injections, then you have to go for vitrectomy. So it is the treatment of endophthalmitis. Whereas panophthalmitis, what you will do panophthalmitis, not respond to vitrectomy or intravitreal injections. You have to remove the contents of the eyeball. The treatment of panophthalmitis is evisceration. You have to remove all the contents of the eyeball. There is no panophthalmitis with no perception of light. If there is no vision, it will extend into the brain, intracranial extension. So you have to remove the contents of the eyeball. Evisceration should be done. Evisceration is the treatment of panophthalmitis. Endophthalmitis, initially you should give intravitreal injections, vancomycin and ceftazidime. There is no response to intravitreal injections, then you have to go for vitrectomy. That is the treatment of endophthalmitis. IFIMA, you should do paracensis and washing because it stains the hemocyte liberated from the lysate RBC will stain the corneal endothelium and cause blurring of vision. Traumatic cataract, should remove the cataract and place an IOL. Lacerations of more than 3 mm should be sutured. Subcontinental hemorrhage, you should wait for 1 to 2 weeks. Give vitamin C, lim C, 500 mg BD. Wait for 1 week, it will resolve spontaneously. Along with that, you should give a painkiller also. This laceration should be sutured. Vertical sutures should be applied, interrupted sutures. If there is any dead necrotic iris, it should be removed, and iris should be cornea should be sutured. This is a rosetic cataract or traumatic cataract. You can see here feathery lines resulting in rosetic cataract. Risk factors for poor visual outcome includes double penetration or perforating injury, dense vitreous hemorrhage, blunt trauma. These are all the risk factors for poor visual outcome. Okay, this is a very small topic. Okay.